Welcome to those of you who are joining us today, promptly at noon Mountain Time. Looks like some folks are still joining, but we want to go ahead and get started. And we have a full agenda today. Very excited to have all of you join us today. We're going to be talking about the Colorado All-Payer Claims Database and how it supports health policy here in Colorado. And I, again, want to welcome all of you joining on the line today. We have some great presenters. Our friends at the Division of Insurance are here. We have Tara Smith, who's the Primary Care and Affordability Director at DOI, Jill Mullen, who's the Policy Advisor at DOI, and then I'm also joined by my colleague, Kristin Paulson, is our CIVHC CEO and President, and I'm Cari Frank. I'm the Vice President of Communication and Marketing here at CIVHC. So just a quick rundown of our agenda today. We're going to be talking just real quickly about CIVHC in case you're joining us for the first time and are unaware of the work that we do. And then we'll be talking the majority of the time about how the Colorado All-Payer Claims Database is supporting policy. We'll talk about just general items, and then we'll go deep dive into how some certain analyses are informing development of policy, how it's supporting implementation of policy, and then also evaluating the impact of policy. And our partners here at DOI who have joined us are going to go over specific use cases of the primary care work that they're doing and out-of-network bill. And then we'll have time for Q&A at the end. But speaking of Q&A, housekeeping items real quick, all lines are muted today. So we would love to hear from you in the chat box. So if you have questions throughout, you don't have to save them till the end, but we will have a formal Q&A at the end. But feel free to use the chat box as we are presenting if questions come up. We are recording this webinar. It will be available to you as well as the slides, and all of those get recorded and posted on our events resources page at civhc.org. So after the fact, you can access all of this information again. So just in terms of CIVHC and who we are, in case you're unaware of our organization, we are a nonprofit organization whose mission is to equip partners and communities in Colorado and across the nation with the resources, services, and unbiased data that is needed to improve healthcare. And we believe that if we achieve our mission, our vision is that everyone will have the opportunity to be healthy and everyone will have access to equitable, affordable, high-quality healthcare. Again, we're a nonprofit organization. We pride ourselves on being independent and objective and service-focused and oriented. We serve a number of different audiences and partners out there in the healthcare space, all with the consumer in the focus in the middle there. We call the folks that we serve change agents, and those are individuals, communities, or organizations working to lower costs, improve care, and make Colorado healthier. So we work with government agencies, our state agency partners that are on the line today, but also researchers, hospitals, clinicians, health plans, employers, nonprofits, you name it, anyone who's touching healthcare and trying to make it better. So we serve in a number of different ways. We are the administrator of the All-Payer Claims Database here in Colorado. We provide public data and non-public data, some of which we're going to be sharing with you today. And then we also have support services. So we have analytic services. We have programmatic services in the areas of palliative care, advanced care planning, and end of life, older adults. We also do a lot of work with community engagement. We conduct program evaluation services as well as research services. So if you're ever needing anything along the lines of data support services, please contact us. We'd love to help you. I'm not going to go into detail about the history of the Colorado All-Payer Claims Database, but I did think it would be remiss if we did not mention that the APCD itself is based on legislation. So it was enacted in 2010 through legislation. It was House Bill 10-1330. And over the years, CIVHC, as the administrator of the APCD, we've been growing the APCD, collecting more data, more information, and making enhancements to the database. making sure that we are utilizing it to its fullest. And then we do produce a few of the reports based on what we have to do as administrators of the APCD, which is in our legislation. And those are two reports, namely our Shop for Care tool, which is our consumer-focused tool that consumers can go online and see how much healthcare services would cost. And then also our community dashboard, which is higher level population health information on cost, quality, access, and utilization of healthcare services. So those are things that we're not going to talk about in detail today, but I did want you to know that those are also reports that we provide as a result of the legislation that enacted the APCD. So just a high-level overview of the APCD and policy. So we provide different analyses depending on the stages of policy that are in place. So we do a lot to inform policy and the conversations that are happening at the Capitol around what would be effective policy and what are the issues surrounding certain topics. We also help support implementation of policy that is put into place, because the data is often needed to help put the policy into place and help to actually enact it. And then we also help with sustaining and understanding policy changes and evaluating the impact that policy is having in Colorado on our healthcare system. So lawmakers often are leaning on the APCD data as an unbiased source of information. It's really important to be able to have those conversations across aisles when you have data that comes from a unbiased source that helps them understand the issues and discuss those solutions. We are also seeing the APCD more and more written regularly into the legislation as a data source to implement policy. And to date, the Colorado APCD has been written into 9 pieces of legislation and has informed over 15 different bills that have taken place. And we are really embedded in state policy in terms of the APCD data that we provide, and a lot more than probably other states. And that's a number of reasons. Number one, again, we're an external body. We're a nonprofit organization who administers the APCD. So we're able to provide that unbiased source of information. A lot of other APCDs are housed in the State Department, so it's a little bit of a different landscape there. But we've done a lot of investment in data quality, which really helps make sure that the data is reliable and that it can be used in those situations. And then we do a lot of intentional, consistent relationship building with our state agency partners, as well as legislators in and out of session, to make sure that they know that this is a resource, the APCD is available to them, and they should be considering using it if it's applicable to the work that they're doing. So in terms of informing, so we'll start at the first stage of before a bill actually goes into place or is written into legislation. These are some examples of how the APCD has informed policy over the years. And a lot of these, actually, I think every single one of these is on our website. They're all available publicly. So if any of these topics are topics of interest to any of you, you can go to civic.org and you can look on our publications page. Most of these are on our publications page. Some are outside of our publications page. But all of these are available, and most of these were requests directly from legislators who were working in these different topic areas like gun violence, wildfire and ozone impact on health, ED use for mental health services, telehealth services. We'll go over a number of these, but again, if any of these are of interest to you, feel free to jump onto our website and you can dig into them a little bit deeper. So the first example we'll go over is the telehealth equity analysis. So this one is a direct partnership between Civic and the Office of eHealth Innovation. The Office of eHealth Innovation does a lot of work to make sure that policy is in place to effectively enhance and continue the use of telehealth and make sure that those services are being accessed equitably and available in an equitable manner. So what we did was we looked at telehealth services in Colorado versus in-person services that could have been performed via telehealth, and looked at the correlation or potential correlation with different social factors like race, English speaking or not, level of education, vehicles, people without internet. And what you see here is the table of the outcomes that we had for this particular analysis, where we saw some correlation between people utilizing telehealth services and whether they had VA status, whether they did not have a vehicle, and then folks without computers or smartphones. So this analysis, this just right here is a very quick snapshot of what's available online. It goes into detailed census tract level data that you can look at those different impacts of telehealth versus in-person at a community level as well. And this next example is EDUs for mental health and potential self-harm. This was a request that we had from a legislator who is very engaged in making sure mental health services are available and that there's healthcare access in hospitals as well. So we looked at a number of things. We looked overall at the population, and then we segmented it by adults versus children, and we looked at trends over time to see what was happening. And this is a snapshot of one of the key findings that we had, which is that we're seeing significant spikes in youth utilizing the ED for mental health or potential self-harm. We saw a rise of 158% in kids utilizing the ED for those services between 2016 and 2021. And overall, 20% of all of the visits that we see in Colorado were for kids in 2021. So some stark findings there. Again, this is a more robust Excel data set that is available online if any of you are interested in looking at this information in a more detailed manner. And also some things that we did during COVID that were really impactful from a policy perspective. We looked at the population in Colorado to try to understand where across the state we had people who had higher risk of getting seriously ill from COVID-19. And this was used by the task force that was set up through the governor's office to determine, you know, maybe we've forgotten, but there was a shortage of the vaccinations back in when they were finally available to us. So we needed to make sure that we were distributing them across the state to the areas that were going to be most impacted. So the analysis that we did here, again, it's another interactive analysis on our website, looked at the different illness factors that were really driving higher risk of getting seriously ill from COVID. And that was used to then focus on where those vaccines were going to be sent and how many vaccines were going to be sent to different counties across the state. We were one of the only states in the nation that had this data readily available, which was really helpful to the folks that needed it at the governor's office who were looking at that information. Let me make sure. It looks like I got kicked off of our PowerPoint slide, or at least it kicked me off. There we go. And another example that we'll share real quick in the implementation stages is the most recent one that we released, which was on firearm related injuries. This is being used to have conversations at the state regarding gun violence and appropriate gun policy and enhancing that where we can. So what we saw in just 2022, we had over 7,000 claims that were related to firearm injury that costs a lot of money in addition to harming a lot of people. And we saw that increased from 2016 to 2022, 53%. By and large, those injuries are happening in the unintentional category. So that's the highest percent bucket. Over 70% of all of the claims that we saw for firearm injuries in 2022 were related to unintentional harm. And then when we looked a little bit deeper at different injury types and at kids versus adults, we definitely saw more adults being harmed by firearm injuries. However, if you look at the orange bars, that's the percent increase for kids. We saw a lot higher percent increase overall for youth under 18. That jumped up 120% across all injury types. And again, that unintentional injury category was the highest increase for kids. So those are just some quick examples of how the CO APCD is supporting the actual discussions before things become bills. So I'm going to turn it over to Kristin Paulson, our CEO, and she's going to be talking about how the policy is, APCD is supporting implementation itself. Thanks, Kristin.
Thanks, Cari. And before I jump into this, I just wanted to answer quickly, Marcia, your question in the chat, pulling from the methodology for the telehealth equity analysis. Telehealth eligible services were identified using CPT-4 and HCPCS procedure codes for services that could be provided either in person or by telehealth. And for example, a surgical visit or something that required an actual in-person presence, such as imaging or surgery, was not included. So anything that had a remote capability or a remote component to it. And that is available on the website on the page for the telehealth equity analysis. Right, thanks, Cari. So I'm going to talk a little bit about the APCD data that's actually being used to implement policy to benefit Coloradans. Can we go to the next slide? So here's a list of the bills that are currently out there that we are currently involved in. You can see there's a number of different pieces that we are actively helping to support. Out-of-network surprise billing, the Prescription Drug Affordability Board. We work a lot with the Behavioral Health Administration and are also supporting sort of the outreach and expansion of primary care and alternative payment models to support primary care across the state. Next slide. So I'll talk a little bit about the Prescription Drug Affordability Board, or PDAB. For this board, the APCD data is used to identify drugs that they'll evaluate for affordability. This board has the ability to set an upper price limit. They also use APCD data to understand the top 15 drugs that payers receive rebates for, and then also understand what these value-based pharmaceutical contracts are. So these are a little bit different of a payment arrangement, and we receive information from the payers about what kind of arrangements they have in place with some of the pharmaceutical manufacturers across the country. Excuse me. So prescription drug rebates. Drug rebates are a file that's fairly unique to Colorado and our APCD. We do collect information from the payers that submit to the APCD regarding how much money they receive in drug rebates. So these are rebates that the manufacturers pay against the full retail price of the drug. And we're able to really look at what's happening with those rebate trends, how much money are the payers getting back from the manufacturers, and what does that mean for spending, both spending at the payer level and spending for consumers and for out-of-pocket. And so this is showing the 2022 overall prescription drug spending summary. And then you can see that that total spend of $5.7 billion is balanced by $1.7 billion in rebates that the payers received. Next slide. So the Behavioral Health Administration is a fairly new administration for the state of Colorado. And there's a requirement in the state legislation that created this administration, too many rhyming words, that they have to be able to track the capacity and performance of all behavioral health providers, including those that have contract with managed care or behavioral health administrative services organizations, and inform needed changes. So we have been working with this team from the beginning to allow them to do that reporting. So we've created measures that focus on behavioral health access and quality. We've created a custom report that is stratified by the various patient demographics, including the ability to look at rural versus urban, and also looking at follow-up care, provider-patient ratio, and other important measures of access. And then we also create a limited data set that we allow the BHA to use to develop new measures that let them look at what's happening in behavioral health visits, obviously not including the substance use disorder claims, and then giving additional demographic information to allow them to look at access and the impact of the access or lack thereof by race and ethnicity, gender, etc. Next slide. Colorado option is another key place where the Colorado APCD plays a pretty important role. The Colorado option standardized plans set a hospital reimbursement floor of 155% of Medicare, and that provider reimbursement can't be less than 138% of Medicare. So the Colorado APCD works with a contractor to be able to process all of our data and basically translate it into terms of Medicare payment. And so you can see in the snapshot there on the facility details, you can look by the specific facility and then find out what their rates look like in terms of the percent of Medicare and what that trend is from 2019 to 2022. So our data is a core part of how those rate settings go and how those rates are interpreted. Next slide. I'm going to turn it over because some of our colleagues at the state, Tara and Jill, are much better versed in talking about the impact of the Colorado APCD in various bills. So Tara is going to start discussing how we have been able to support them in investing in primary care. Tara?
Thank you so much, Kristin. Thank you, Civic, for the opportunity to join you all today. So again, my name is Tara Smith. I'm the Primary Care and Affordability Director at the DOI. And I'm here. I think you saw two of our bills on that list, or two of the primary care related bills on the list. I'm here to talk to you about how the division has and is continuing to leverage APC data as part of this body of work. So if you want to go ahead and go to the next slide, I do think primary care actually offers a great case study of how the APCD has been incorporated and leveraged at kind of all stages of the policy cycle. So that big P policy level down to little p policy implementation, and then even looking forward into how we would love to be using this data to help with future evaluation of our primary care efforts. So really starting at that big P level and at the place where a big P policy is generated in pretty much every state with our state General Assembly. I think several people on this call are probably recovering from the most recent session, which recently wrapped up. But when you think about the primary care context in Colorado, that framework in recent years has really been established through these two pieces of legislation that you see highlighted here. So back in 2019, the legislature passed House Bill 19-1233 to grossly oversimplify really kind of the key legislative directive coming out of that bill was that the state of Colorado, with the division playing a role in that, really needed to increase the amount of investment that was happening in primary care. So there's a lot of data out there that supports that. Primary care really does play an integral role in improving patient health outcomes, that it can play a key role in reducing health disparities, and that it's very effective as a tool in controlling healthcare costs over time. But we know that Colorado as a state, just like about every other state in the US, and the US really as a nation, is currently underfunding primary care. So when you look at how a healthcare dollars, very few cents actually go into primary care. And so really the purpose of this bill was, as a state, we need to flip that script. We need to start investing more in this key area. Second bill you see was passed in 2022 and really grew out of conversations about how and where we should be making that investment. So for those that aren't familiar with the term alternative payment model, essentially it's a different way of paying for care. So as we're thinking about increasing investment in primary care, the idea is that we don't just want to be growing the amount of dollars in that one area of the healthcare system and thereby just increasing the overall amount that's being spent. We know that healthcare costs are escalating already. And so the idea here is, can we be making that investment in strategic ways that are actually driving value into the system? So rewarding based on the value of care rather than the volume. And that's essentially what an alternative payment model is. So the second bill was really designed to complement those efforts by increasing the strategies that we're using to make those investments wisely. So as we transition into the next slide, one of the things that happened in that 2019 bill was to create something called the Primary Care Payment Reform Collaborative. At a high level, again, to grossly oversimplify, this is a multi-stakeholder group, so it includes payers, both public and private. It includes healthcare providers and healthcare consumers. And you see on this slide the list of statutory responsibilities that this group is tasked with. It's facilitated by the Division of Insurance. Really, this group is designed to bring the key stakeholders together to be making recommendations around things like, how are we defining primary care? What should that target level of investment be? And how can we be decreasing barriers to the use of APMs? But really the key piece I want to focus here on is that second directive, which is really around the ability to analyze the percentage of medical expenses allocated to primary care. So if you want to go to the next slide. This is one of the places where APCD, even at the time Big P policy was being made, that the APCD was explicitly incorporated. So the division partners with CIVHC. CIVHC every year provides an annual report to the division and the collaborative that includes data on primary care spending. That's for commercial carriers, that's for our state Medicaid program and the CHIP program. And essentially it's the amount of dollars that are flowing to primary care, the amount of total medical expenditures that are going through these APMs, through these value-based payments. And then in relation to that more recent bill, the 2022 bill, data around the aligned quality measure sets, as we're thinking about APMs and how we want to better utilize those as a strategy. They're quality measures. So the entire idea is that this collaborative should not be making recommendations in the dark. Really wanted them to be evidence-based. So if you want to go to the next slide. This was a horrific slide choice for a short presentation. There's a ton of information on here at a high level. This is how we collect that data, right? The numerator is essentially primary care spending. Denominator is total medical expenditures. So we're really trying to tease that out. One thing I will note is that Colorado's methodology is really one of the more sophisticated state collection mechanisms in that we do incorporate both claims and non-claims-based spending. It's really challenging to try to collect data around APMs, but we work with carriers and with our partners because we feel like that gives us really the best data to be making these policy decisions off of. So if you want to go to the next slide, what does the collaborative then do with this data? You get these annual reports as a group, and really they use this information to inform the series of recommendations they put forth in an annual report every year. All of these reports are available through that link that you see below, but essentially each year there are certain themes that the collaborative offers these recommendations. In that initial report, you really got to a definition of primary care, which set up the methodology we use. And then I've had several reports looking again at APM's payer alignment. If you want to go to the next slide. In 2023, coming out of that bill, some specific recommendations around what parameters of APMs would do best with alignment. And then the most recent report was focused on behavioral health integration, which we know behavioral health needs are a huge component, and the collaborative contribution to that state conversation. So if you want to go to the next slide. So then what does it mean for the collaborative to make a recommendation? And this is really where we're using this data to inform little p policy recommendations. So some regulations that the division has put out, this initial recommendation for 272 actually set a primary care investment target for the state of Colorado. Again, not a pretty complicated slide. I will just say this investment target was essentially for the commercial carriers that the DOI has regulatory authority over. There's a requirement that they increase the amount of total medical expenditures flowing to primary care. They're allocated to primary care by 1% in 2022 and 2023. So we're about midway through a cycle of evaluating that investment target. Ooh, it's a good thing I'm about out of time because my voice is going. Do you want to go to the next slide? And then a second regulation that was more recently promulgated looks at that aligned quality measure set. Again, through this regulation, there's an adult measure set and a pediatric measure set that carriers are required to incorporate now. And we'll be collecting and reviewing that through CIVHC data, or through data that's submitted to the APCD. So last slide. Some future goals. As we're putting these now regulations and requirements in place, we want to be able to analyze what's the impact of an investment target, what's the impact of aligned quality measures. So future goals are to continue to iterate with CIVHC, with stakeholders to improve care and APM data collection. health equity is forefront of mind in any evaluation effort. And then specifically doing some deeper dives around behavioral health integration, kind of all future goals in this space. So I will stop there and hand it off to you, Jill, to talk a little bit about our work.
Thanks, Tara. Good afternoon, everyone. My name is Jill, and I am a policy advisor at the DOI. I'm just going to discuss a little bit about how the DOI uses APCD data to inform our implementation and enforcement of our surprise billing law. So next slide, please. So just some quick background. Colorado's passed surprise billing protections in 2019 with HB 1174. The bill does lots of things, but primarily it protects individuals from surprise medical bills when receiving emergency care from an out-of-network provider or facility, or receiving non-emergency care at an in-network facility from an out-of-network provider. I will mention, our surprise billing law really applies to DOI regulated plans. And one of the important aspects of ours that I was gonna dive into a little bit today is that 1174 sets up a payment framework for carriers to utilize when making payments to out-of-network providers. And so this payment framework that was set up in the bill utilizes APCD data, and that's what we're gonna kind of talk about today. But I just sort of wanted to mention also the federal government sort of stepped into this space as well. They also passed legislation, the No Surprises Act, in late 2020, which went into effect in January 1, 2022. And the NSA it has several differences between Colorado's surprise billing law, but the feds were really clear that the NSA is a floor and states can adopt protections on top of what's in the NSA. But also, to the effect that an existing state law didn't conflict with the NSA, those protections can stay. And so this is really relevant because the NSA does not include a payment methodology. It does have something called the qualifying payment amount, which is the basis for determining an individual's cost sharing. But that qualifying payment amount, that QPA, it can be considered in an independent dispute resolution between a provider and a carrier, but it's not the final rate. And so, folks may be familiar, but the Fed's IDR process has been a little tangled up in some litigation, but also just the sheer numbers of how many IDR disputes have been filed is notable. I pulled some stats recently that from April 2022 to April 2023, about 335,000 disputes were initiated through that federal IDR process. So it's just really clear, providers and carriers are maybe just not in agreement on what these rates for out-of-network claims should be, and it's sort of initiating a lot of arbitrations. And so in Colorado, we kind of decided to keep our payment framework because we thought maybe that this would, prevent confusion between carriers and providers on what to do in these out-of-network situations. So for example, in 2022, the division, we only received 21 arbitration requests and only about 17 of those actually went to arbitration. So next slide, please. So yeah, I think this is kind of a testament to that our payment methods are sort of working because we have great APCD data that we can rely on. And so I just wanted to sort of put up here, this is what the payment method that we put into 1174. I know the slide is like a little bit wordy, but just to sort of give you an idea of what these payment methods are, we have for provider and then we have for facility. It's the greater of 110% of the carrier's median in-network rate, or 60th percentile of the in-network rate of reimbursement for the same service in the same geographic area based on data from the APCD. It can always be a negotiated independent rate, but I think we're mostly seeing it's one of the first two, and then it's the greater of those two. And so next slide, please. Yeah, so as a result of the legislation, the APCD data is posted on the DOI's website, but, calculating 110% of a carrier's median and network rate isn't really a rate that we have insight into, right? That's calculated by the carrier. And so 1174 includes a provision that a provider facility can request from the DOI data from the carrier to evaluate the carrier's compliance in paying that highest rate. And so because that was in the legislation, the division created Regulation 4-2-79, which implements the out-of-network data request and response form. I'm a visual person, so I threw up this is kind of what the form looks like, but it's very small, so don't worry about reading all these columns. It's just to sort of show it as an example. You know, the provider will submit this form to us and they'll fill out everything in the purple columns, which essentially says, you know, what the claim number is, what geographic region the claim was in, you know, the amount paid, and then the DOI submits this to the carrier, and the carrier will need to fill out, you know, what was the median and network rate, and then fill out the APCD rate. And then we can actually see to ensure compliance with the original law, right? Did they pay the higher of the two rates? And so we actually received quite a bit of these forms right when the bill was initially passed, right? Because there was just some implementation, you know, what are these rates, calculating these rates, making sure that we, you know, folks can see the APCD data and look through the tables and determine that, like, right, making sure that they're looking at the right rate. But, you know, as it's been several years since we've implemented this law, we're getting less and less of these requests. But, you know, sometimes we get them from providers to sort of help inform the arbitration process. But again, you know, we don't get a ton of arbitrations. Next slide, please. Again, I'm a visual person, so I thought I would just throw up here sort of what some of the APCD rates that are up on our website look like. This is for ER levels. So say a carrier receives a claim from an out-of-network facility for an ER level 2 in region 3, which is Denver. The carrier can pull up this table. The provider can also pull up this table and sort of see, you know, ER level 2, region 3, $850. You know, these rates have also been really helpful when a carrier doesn't have a rate for a particular region. You know, maybe a carrier doesn't necessarily offer plans in region 5, which is Grand Junction. You know, they can get a claim from there, and then they will likely use the APCD information in order to determine how to pay that claim. Again, very transparent, right? You know, anybody can go on our website and see these rates. And so just, you know, from a policy perspective, I think the APCD data has really made these payment methods possible. So it's great that Colorado has this type of information and that we can set up a payment methodology for out-of-network billing, because I think this has really helped our surprise billing laws be successful and helped with implementation. And, you know, really the goal is to keep the consumer out of these transactions. And so I also think that it's been really helpful in, you know, keeping the consumer out of it and sort of helping the DOI also with implementation and making sure that carriers and providers are, you know, following these rates. And so that's everything that I had. I think I will be turning it back over to Civic.
Thank you, Jill and Tara. Final section of our presentation today, and then we're going to open it up to Q&A, is to talk about how the APCD is used to evaluate the impact of policy that has been passed. So CIVHC's used at the very beginning to inform how policy should be structured. It's used to actually implement the policy, as Tara and Jill just walked you through. And then we're also used to evaluate how policy has had an impact and how it's affecting Coloradans. Could we go to the next slide? So here are a number of pieces of legislation that have passed where CIVHC is involved in really evaluating how things have changed Coloradans' abilities to access healthcare, use healthcare, and how really they're being affected by the laws that we pass. Next slide. So the provider payment tool is a fantastic example of that. This was a piece of legislation that was passed to really give transparency into variations of provider payments across the state. It was actually designed so that it aligned with the out-of-network rates that Jill was just walking through. And so for every CPT, this tool provides the average, the 25th percentile, 50th percentile, 60th percentile, and 75th percentile of payments. This has variations where you can look at the place of service, you can look at different providers in different settings, you can look at different geographies, whether you want to see the state or DOI regions or counties. You can look at what kind of payer or what kind of insurance you want to examine, and a variety of other sort of gears and other breakdowns. Go to the next slide, I believe. So here is one use case. I do want to call out that there is an anesthesiology tool specifically in the provider tool that was built by our analyst team that allows you to actually use the modifiers and time components to look at anesthesiology billing. This is one of the key use cases that was actually in mind when legislators put this bill through. But this is really looking at, in this example, what do anesthesiologists in Arapahoe County get paid to perform a 45-minute inpatient appendectomy on a healthy patient. And you can see the variation in reimbursement for those anesthesiologists here on this graph. Next slide. So another piece that we have been, that we built at the beginning of the pandemic and then have been refreshing and tracking and building on ever since was really looking at telehealth versus inpatient payments. There were a lot of changes that were being made to reimbursement for telehealth during the pandemic to sort of counter the lack of preventive services and the lack of checkups that people were having. And so we're tracking that to see how that impacts utilization and how that has been consistently or how that's been evolving since the peak of the pandemic. And you can see some of the variations here. So in 2020, as we were going into the pandemic, over half the codes evaluated telehealth reimbursed lower than in-person patients or in-person payments. I can't talk today, I apologize. And in 2021, due to some of the changes that were made at the state level, more than half of the codes evaluated had lower payments for telehealth than in-person. I'm sorry. Oh, fewer than half. I apologize. Fewer than half the codes had a lower payment for telehealth. So you can see the progress there as we were reimbursing more for telehealth services over time. Next slide. Gender affirming care. This is it's a very simple evaluation, but it actually was a fairly impactful evaluation for Civic. This looks at the number of people across the state that were receiving gender affirming care for both commercial markets and the Medicaid market. And this looks at sort of that progression over time as Medicaid started reimbursing for gender affirming services. And you can see the rate. It starts at 2.4 per 100,000 covered lives in 2016, and in 2021 jumping to 11.1 per 100,000 covered lives, in large part due to changes in how we reimburse for those services. Next slide. And then this is just a list of a variety of other public reports that are available on civic.org. You can see they run the gamut from looking at our health equity analysis to community dashboards, which provide a lot of cost, utilization, and quality measures by county for the entire state of Colorado. We have additional information on the alternative payment models that were mentioned earlier. We've got evaluations on low value care and a number of different analyses that allow folks to really investigate what's happening in healthcare in Colorado and where we have room to improve. So I think, Cari, we're going to be opening this up to Q&A for those.
Yeah, and I know that we've received a few questions already in the chat, and some of them have been addressed, but just a reminder, if you have any questions on anything we presented, I know we threw a lot of information at you, and each one of these reports has a ton of data that you could get lost in for the next 6 months if you wanted to. So feel free to ask any questions related to anything that we presented. And as you guys are entering things in, we can go ahead and go back to some of the questions that we received. And some of them are just comments. But I think we already addressed the one from Marcia on how we determined the telehealth services. So I see one after that from Andy, very curious about the 42% reduction in self-harm injuries in 2022. That's related to the firearm injury analysis. If you go on our publications page, Andy, you can request to download that data and look at it in even more detail. Our infographic shows that there was a big spike in self-harm, particularly in rural communities in 2021 during the pandemic time. So that might be where we're seeing significant decreases in self-harm, as obviously the pandemic was causing all sorts of chaos. So that might be something to look into, is some of that demographic information regionally and across ages, and different categories. So feel free to, if you go onto our website, there's just a little Google form that we ask how you're going to use the data, and just so we can track who's using it and for what purposes, and we'll send you the link to the Excel file. And comment from Tom Keller, maybe Kristin, you might want to take this. We need SUD claims data.
Yes. We do need SUD claims data. And I think there's another question that was just put in there from Kristin asking any plans to make substance use disorder claims more available. Well, we don't really get much in the way of substance use disorder claims. Those are currently, for the most part, retained at the payer level. There are many active conversations, including, Paul, you referenced the prevention bill that was passed this session, which we were part of. And we very much would want to be collecting those. So we're talking about ways we might be able to do that would make sort of everyone a little bit more comfortable. Obviously, those are very sensitive claims to be having. And so, thinking through, is there a mechanism for us to collect them in a de-identified way that would be useful in terms of connecting with the APCD or our reporting? But how do we really make sure that we have adequate protections on those? There were some changes that were recently made to 42 CFR Part 2, which is the federal guidance that governs access and utilization to SUD claims. And they did clarify that an APCD is a lawful holder. We can hold those claims and use them for disaggregated reporting, but we are still in the process of trying to bring those claims in. But we are definitely working in that space as well.
Great, thank you. Are we collecting data about ambulance billing? That's another question.
We collect data on anything that is billable through insurance. So if the ambulance charges are covered through an insurance claim, even if it's out of network, we will receive those claims. So yes, we do have ambulance billing claims.
Yeah, we do think it's limited though, because not a lot of ambulance bills get covered. So I think there was a Kaiser Health study that was done that estimated only 20 to 30% of all ambulance claims. So we anticipate we have about 20 to 30% of the claims as a result. So it's not as robust as we would like because of the way that gets billed and paid. Right. Let's see, what is the lag for receiving claims data? Are changes reflected if claims are disputed and appealed? Sometimes that can take a very long time to get resolved. Yes, it can indeed.
So we receive the claims data monthly, and typically that reflects paid dates in the previous 30 days. We update the database every 2 months. But generally, we wait until we have 6 months of run out to release that data or use that data. There are a couple of limited use cases where we're really looking only at enrollment or eligibility. We're not actually looking for those adjudications. And so we can work with those data a little earlier. But typically, it's a 6-month rollout for us to achieve 97% plus final adjudication. As you note, there's still the possibility for changes to those charges that go out a year, 2 years, sometimes even more. And those changes are reflected in the payer's submissions. And so we do find that occasionally we will get things that go a couple of years back and change numbers from several years prior. This is why we're very careful to note claim versioning on our data sets when we release them, because there can be changes to a full data set because of those lagged adjudications. But at 6 months, that's when we're comfortable releasing the data, and it's over 97% final claims data.
Great. And then another question about the new SHE that's getting developed, the Data Hub for Social Health Information Exchange, and whether we will be engaged.
We are engaged. We are very engaged in it. Well, as much as we can be. We've been working with OEHI. We're having conversations. There is an expectation that Civic will be able to work with that data and bring that data in to see how that interacts with the healthcare data, with health claims, with health severity. We know that we're going to be asked to do some evaluation of the impact of addressing some of these social needs. And so we're working with OEHI and others to make sure that we'll be able to collaborate with them and bring the data together to really inform as much as possible how we need to be rolling out these services and how we can best support Coloradans. So very engaged with that process.
And then a very specific use case question. Can we analyze claims for sexually transmitted diseases, prevalence and cost of care from 2013 to 2021? That would be definitely a good use case of the APCD. Definitely possible.
Yes, it is definitely possible given the data in the APCD. And then Tom Keller, to your question there, we are in fact using claims data changes to analyze and address the 700,000 Medicaid enrollment drop. That is one of our use cases with Medicaid, and we have been doing that for 8 or 9 months now. But we are working very closely with Medicaid to look at those changes and help them figure out how to address those needs. But that is absolutely one of the current use cases, and it will be going on. We just worked with the state. We'll be continuing to run those evaluations for them and run those claims for them for the next year as well, multiple times over the next year.
Great. I think we caught all of the questions that I could see. Any last final questions? Pop them into the chat, but I will make a plug for our next data to drive decisions. It's actually focused on the funding support that we have available. For example, for the use case that was just provided, certain types of entities can qualify for either our scholarship program to get non-public data sets from us or custom reports, or through our new health equity fund that is in partnership with the Colorado Health Foundation. So we're going to be going over those two programs and how folks can access them and who's eligible, all of the details and how the application process works. That is going to be on June 20th. So mark your calendars, noon to 1. That's our typical Thursday that we normally do our data to drive decisions. We're back on the Thursday for next month. So that 12 to 1, that'll be on scholarship and health equity. So look for more information via email to register for that event coming up. So we appreciate so much our friends and partners at DOI. Thank you, Tara and Jill, for coming and for being so articulate about the projects that you guys are working on. And we appreciate you from just being Coloradans on the work that you guys are doing, such important things at the DOI. And thank you, Kristin, for being here as well. And thanks to all the participants. We will be sending out a survey and link to the recording and the slides shortly. So be looking for that, and feel free to reach out to us at any point in time if you have more questions or comments or things you want us to cover in these events as well. So thanks to everyone. Have a great rest of your afternoon.